So this is easily can be seen in the biochemistry of this hemoglobin, and this is the picture in this kind of patient. And this hydrophobic result in the vaso-occlusion, obstruction of the capillary in the hand and in the feet. We as normal has got this RBC as normal, in them they are nucleated, or maybe this sickle cell anemia. When they change to oxygen, to deoxygenate, they would be clumped, or maybe they would be polymerization and precipitation of hemoglobin S in the mixture tubule, result in the block of the capillary. Normal RBC has the life of 120 days. We are normal, the hemoglobin alive for 120 days. You will see there is no nucleus in the RBC. This is white blood cell, and there is no sickle cell anemia hemoglobin. Here you will see the picture of erythrocyte is not normal. You will see reticulocyte. Also you will see this one, which is sickle cell anemia. The survival of this kind of cells will be 10 to 20 days. So they will be dead in the spleen. It results in the splenomegaly, and instead of 120 days, only 10 to 20 days, which means they are all the time anemic. So mutant gene, abnormal beta polypeptide hemoglobin S, low solubility because there is hydrophobic in that patient of reduced hemoglobin S. The number is reduced, low solubility is there. Increased viscosity and clumping of the cell resulting in ischemia, thrombosis, and infarction. In the extremes, it will be limb pain. In heart, result in heart failure. In lung, result in pneumonia. In gut, result in the abdominal pain. It will be pleiotropy. Pleiotropic effect means one gene mutation, several sign and symptom out of it in different tissue. Pleiotropy means one gene mutation result in different phenotype in different tissue. Why this happened? All because of this sickling. Also destruction of sickle cell result in the anemia, result in the splenomegaly, result in the weakness, result in the abnormal skull radiograph. All of them would be pleiotropy, one gene mutation, several phenotype in different tissue. So this patient in the infancy, early life, they will go for hepatosplenomegaly. The function as spleen is not good enough. They are at risk for infection because the spleen is not removing any invasion or invader. Delay in growth, hand-foot syndrome, or dactylitis. Itis means inflammation in the finger. Dactylitis, we do have a painful swelling of hand and feet due to capillary occlusion, especially when the patient says, when I'm flighting, I will see this pain in the hand and feet. Or maybe I went to climb a mountain, then the pain will start. This means hand and foot syndrome or dactylitis due to sickle cell anemia disorder. When they are bigger, they are at risk for a stroke. For the heart, we say myocardial infarction. For the CNS, we say a stroke, means brain infarction. Also, they are at risk for gallstone, chest episode of pain, recurrent pain episode, and delayed puberty because of this kind of clump occlusion of the different vessels. In adult life, we do have leg ulcer, bone disease, ophthalmic complication, pregnancy complication, head organ damage, respiratory and renal failure in the sickle cell anemia patient due to capillary occlusion. This is autosomal recessive disorder. The father is fine, mother is fine. Both of them are carrier of this mutation. 25% risk in each pregnancy for each patient to have the disorder. For the sickle cell anemia, we have it much more in the Bandar Abbas province, in the Bushehr province, near to the Persian Gulf area. Both alleles should be mutated. Why this is much more there? Because of the heterozygous advantage they have. The malaria parasite will go for parasitemia and severe malaria, result in death. But the people who has got this mutation as a carrier, as a trait, they are persistent against it. Why this not happen to them? Because the RBC has a power, the parasite will not go invading inside the red blood cell. Of course, they are at risk for splenic infarction, same as myocardial infarction or brain infarction. Because of that, we have to remove the spleen when it is bigger than enough, especially when they are flighting with radioscopy cabin pressure. So we asked them, if you wanted to go from Iran to US, please have a stop in Turkey, then have a stop in, for example, UK, then go there. Long distance flight is very dangerous for this kind of patient. Also, if they go to Damavan or to Shahrikor, because they are in the high altitude. Exactly the same distribution we saw on the falciparum malaria, which you can see here in the Saudi Arabia, in Yemen, in Emirates, and in the Central Africa, also in Turkey. Exactly the same is for the sickle cell gene mutation, means heterozygous advantage. This is the same for Vibrio cholera as well. For Vaba in Farsi or Vibrio cholera. Of course, I know in Iraq it's used as Vaba, but it was interesting. I saw the Vaba means something result in the huge number of deaths. For the corona, again they said Vaba. You are from Iraq, yeah? No Iraqi here? Have you heard Vaba?
Vaba? No.
Yeah, even I saw for the corona they saw using Vaba. Means something result. Are you from Iraq? Bahrain. Maybe in Bahrain is the same, Vaba. Have you heard this?
Vaba, yeah.
Vaba in Farsi or in the English language means Vibrio cholera, result in the diarrhea. But in Arabic language, Vaba means something, parasite or virus or something, result in the huge number of deaths.
But this
is the same. For Vibrio cholera or malaria, both they have heterozygous advantage when they are in the trait, not the patient, not the normal. Only the trait has got this heterozygous advantage.
you forget one letter.
Okay. Okay. How is the prognosis for sickle cell anemia? Again, we have a kind of variation. You see, the mutation is one point, it is a hot spot, but the patients are different from each other and we don't know why. Some go well, some go poor. We have to go for the bone marrow transplantation. The life expectancy is 40 to 50 years. In Iran, we have life expectancy for healthy to be 74 to 79. Depends on men or women. Lady would be older, 79. Men would be 75, you know, lady killing the men. But for this kind of patients, sickle cell anemia is 40 to 50, means 20 or 30 years earlier. The supportive would be blood transfusion. Also, we give them antibiotic. Otherwise, they are at risk for the infection because the aspirin is not working well. Also, when we go for a splenectomy, we should give them vaccine of pneumococc every year. If you heard somebody did a splenectomy, we should ask them, are you doing pneumococc vaccine every year? Otherwise, there will be at risk for pneumonia. Of course, we should manage the pain. The only treatment would be allogenic bone marrow transplantation, and we don't have gene therapy till now. Maybe in the near future for hemophilia, for the sickle cell anemia, there would be some gene therapy FDA approved. For the diagnosis, we have to check for hemoglobin electrophoresis. In there, we will see hemoglobin S is increasing. So we should check for the mutation, and you will have to check for the baby. In 40 states of the US, they do a screening for the newborn. And for the sickle cell anemia, again, we can go for therapeutic abortion because there is a big problem for the baby. Usually, we check for the PCR RFLP, and the enzyme is MST2. Normal people has got one normal allele with a small size. These two are carrier. This one is a sickle cell anemia patient. These two are trait, normal, and this one is the patient. So all the time, this is the case, which is not usual in different single gene disorder. One mutation, one disorder only. So usually we check for full blood count. We see hypocolon macrocytic is there. It results in the iron deficiency or thalassemia. If we go for hemoglobin electrophoresis, as we see hemoglobin S, we should check, is it patient or is it carrier? And other carrier of hemoglobin variants, same as D and G. This is not important. Even 2D or 2G can marry each other. There won't be big issue, same as alpha thalassemia or beta thalassemia. D and G is fine. It's not a kind of disorder. This is much more trait. Let's go for hemophilia, coagulopathy. Forget about hemoglobinopathy. Pathy means pathology. There is something wrong. Here, the coagulation is the problem. We have two kinds of hemophilia. It is X recessive. Means in the pedigree only the boys are affected. Maybe ladies are carrier, and we usually ask, what about the uncle of the baby? Brother of the mother has got the disorder, mother is carrier, the baby has got the disorder. That's the usual way. 1 in 5,000 of newborn male has got the chance to go for hemophilia A. Hemophilia B is 1 in 40,000. 8 times less common hemophilia B than hemophilia A. Interestingly, the clinics of the hemophilia A and B is the same. You can say you have the hemophilia disorder. Please go coagulation factor activity. Usually we do this test only in the blood transfusion organization. It's not in the usual laboratory to have it. We do not check the number of amount of factor 8 or amount of factor 9. We check for the activity of factor 8 and factor 9. Interestingly, hemophilia A is the classic, hemophilia B is Christmas. Means in the time of Christmas they forgot to have the factor, they will go for bleeding. It's usual in the Christmas time, same as it is usual in the Nowruz time of Iran, if the mother and father forget to give the factor to the baby. 30% of the hemoglobin A is new mutation, de novo mutation. Father is fine, mother is fine, the baby has got it for the first time. 1 in 30 is due to that, but in the hemophilia B is not common to have it as a kind of mutation there. We as normal, when there is bleeding, the vessel would be constrict, the plaque would be there, and then fibrin clot. That's normal. You say, okay, I had a bleeding, after 2-3 minutes, 5 minutes, it was clotted. We say, Alhamdulillah. The platelet clot, fibrin is working very well. But this hemophilia patient, they have the bleeding, vessel is constrict, this one is working, but there is not enough for complete platelet clot. Formation of fibrin clot is incomplete. They are bleeding, and there will be a big danger for death for this kind of patient. We have two pathways, extrinsic and intrinsic. Intrinsic factor pathway has got different elements. Factor 12, activate factor 10, activate factor 9. activate factor 8, activate factor 10, then we will prothrombin, fibrinogen, and fibrin clot. But in the extrinsic pathway, only factor 7 is there. So when we wanted to do circumcision or any surgery for hemophilia A patient, we ask them, please find factor 7 to be there. If the clotting is not working, we have to give them factor 7. Factor 7 is working very quickly, only one item. Here you see 1, 2, 3, 4, 5, 6, 7 to be fibrin clotting there. Okay? We usually have factor 7 as the biotech. We have a kind of biotechnology to have factor 7 as a drug, but for factor 8 and factor 9, it is plasma-derived drug. We usually use it. The interesting question is why coagulation is a complicated. Why we should item 1, then item 2, then item 3. Do you have any answer for that? Why the pathway is very complicated? Easily, why we don't go, for example, one item result in the fibrin clotting? Because if it was very easy, we are at risk to go for infarction all the time. It should be complicated, so not easily for coagulation. The danger of coagulation is brain infarction, myocardial infarction. Hopefully, because it is several items, it's not usual to go for coagulation all the time. But this is the picture of a patient with hemophilia A. They have bleeding usually in the joint, elbow joint, maybe in the muscle or even in the skin with a very minor lesion. They have the bleeding sign there. And if not treated, it will be several weeks. Usually we, as normal, it's only 2-3 days, everything will be fine. After trauma, mild trauma, but they will go for bleeding for a long time. Bleeding result in the pain. Bleeding in the long term result on the several troubles, especially in the joint. And the danger is internal bleeding, same as, for example, retroperitoneal, maybe in the stomach, maybe bleeding in the CNS, result in the death of the hemophilia patient. This is a normal knee joint picture radiography. In hemophilia, you will see this one. The distance between two knees is very low, and also there are a lot of fibrin result on the not very easily flexing of the knee joint. This patient, hemophilia patient, has got the bleeding result in the arthrosis, result in the impaired joint movement. Joint bleeding, pain, insufficient treatment of pain, immobility, recovery, fear of new bleeding, and anxiety from the others. Maybe he pushed me. Be careful, be careful. It results on the protection and overprotection. We say hemophilia is not a disease of the patient. It is a disease of the family. All the family are taking care of this baby. Maybe it is bleeding, and they would be very excited all the time. Fear is there. Maybe depression is there. It is X-linked recessive disorder, which means this is usual. The mother has got the mutation, father is fine. 50% of the girl would be carrier again, same as the mother. But the ladies are normal. There is no hemophilia patient in the ladies. The male has got 50% risk to be patient. 50% would be normal. Depends on which X is coming. Mutated X or normal X. Normal X, normal. Mutated X, the boy would be patient. Lady, 50% risk to be carrier. That's the usual way. If you ask this lady, what about your brother? He says, yeah, I had a brother who was dead because of the hemophilia. The brother has it, the disorder, the mother is carrier. This is the usual way. Otherwise, if is it for the first time, de novo mutation, so it will come down, and it is the first time. This one is not usual. A man with hemophilia marries somebody because they are in danger, they are at risk. Forget about having forget about marriage. I don't want to have a baby. It's usual. But if it's happened and they will go for having a baby, both girl would be carrier, boys are fine because the X is from the father. They are 50%. So they will give the X to the ladies, the Y for boys. Boys are normal, girls are carrier, both of them. This is not usual. They will not go for marriage, they will not go for having a baby. This one is very usual. Okay, do you have a question? No. If we check for the activity of the factor, it would be severe, moderate, and mild. The severe means less than 1% factor 8 or factor 9 they have. Less than 1%. Nothing. 0. Pattern of bleeding episode 24 to 48 per year means 2 per month to 4 per month. Without any reason they are bleeding. Cause of bleeding episode is spontaneous. There is, even without trauma they will go for bleeding if there is no treatment. In the moderate they have 1 to 5% activity, 4 to 6 per year bleeding. After a minor trauma, they will do bleeding. The mild one, between 5 to 40% activity, bleeding is not usual. After major trauma, for example, car accident, or maybe after surgery, they will show for the first time they are bleeding. We have to give them factor 7 to take care of death of this kind of patient. The prognosis, sometimes they go well, sometimes depends on the severity of disorder, sometimes it is poor. We give them factor replacement therapy. Sometimes if you go for enzyme replacement therapy in metabolic disorder, or hormone replacement therapy for somebody who has the hormone problem, same as the menopause ladies. Here we have factor replacement therapy. We will give them factor 8 or factor 9, depends on the disorder, one of the plasma-derived drugs. And interestingly, sometimes we have inhibitor, especially if the treatment would be delayed. We don't know this is hemophilia A or hemophilia B patient. After some time we realize, we give them factor 8 or factor 9, there is no treatment. In some patients we have this kind of inhibition, and we don't know why this has happened to some patients. Even we give them factor 8 or factor 9, there is no treatment because of this inhibition. Ask your question?
Professor, how are these factors produced?
How it is produced? When you give your blood, we will have it centrifuge, we have the plasma, we derive this drug by the drug factory, factor 8, factor 9. Of course, we do have a factor 8 recombinant one by biotech technique, but all the doctors says the factor 8 and 9 derived from the human plasma is better than the recombinant one, biotech
For
one.
example, if I have hemophilia, can I use factor 8?
Yes, when we have the factor, because there is no cell inside, it doesn't mean we should use the same factor from the same blood group. Everyone can use the factor 8 or factor 9 from the factory, not from the exact person. Please give me your factor 8. There is no factor 8. Factor 8 is in the plasma. It should be derived from the plasma by the factory. If we don't have enough factor 8 or factor 9, we will go for first frozen plasma. Maybe you are asking this one. FFP means, for example, in the accident, in the earthquake, in the storm, we will go for FFP, first frozen plasma, which means all the plasma plus albumin plus IVIG, factor 8, factor 9 is there. We have to give it because it is an emergency situation.
Professor, and what should we do in case of inhibition?
In case of
Inhibition.
inhibition,
Yeah.
we have to give them cortisol, anti-inflammatory things.
Cotton?
Yeah. If there is inhibition, we have to use inhibitor, anti-inflammation. CNS bleeding is the leading cause of the death in the hemophilia patient. Before CNS bleeding, because of the bleeding in the joint, there is pain. But when there is bleeding in the CNS, unfortunately, they will go for the death. IV, it would be IV, there is no intradermal or maybe eating factor 7 tablets, there is nothing. It is liquid and should be given in IV. Lifestyle change, avoid injury, and hopefully in the future there would be gene therapy. There are some promising way, but it needs much more time to go further in this regard. And I told you, if there is surgery or if there is car accident, we have to go factor 7 to be careful of bleeding on that emergency situation. Okay, nearly finalized. Conclusion, we do have hemoglobinopathy, we have the coagulopathy, and we told you different issue. Deletion is much more in alpha thalassemia, point mutation is much more in the beta thalassemia. Please read the slides and also the book. The last one is leukocyte. I told you regarding RBC, I told you about factor 8 and factor 9 and also plus platelet. Here is about leukocyte. We as normal, we have plasma, leukocyte and erythrocyte, and also formation of the cells. The white blood cell, which is the Buffy coat, we have it as a granulocyte, famously neutrophil, 40 to 70%, eosinophil 1 to 4%, basophil 0.1%, lymphocyte, agranulocyte 20 to 45%, and also monocyte. In the patient who has got allergy, we do have higher amount of eosinophil. In the infection, we will have neutrophil in the acute phase, lymphocyte in the chronic phase. But this is the normal white blood cell. We usually have 4,000, 5,000, 7,000 in infection. We are normal tax cut. But a patient with leukemia will report white blood cell 20,000, 30,000, 50,000. The white blood cell is too much, but it's not effective. They are at risk for the infection and they would be dead if there is no treatment. Otherwise, we should go for leukemia and lymphoma, and they are normal, very good working in our health, and we are immune against infection, thanks God. We are normal. If this number would be increased in the lymphocyte, we will go for leukemia. Or myelocyte, we will go for acute myelodysplastic leukemia. Is it acute? Is it chronic? Usually, children go for acute, and elder go for chronic ones. But maybe sometimes for an old person, AML, ALL is coming, and unfortunately, we usually go for treatment for the chemotherapy, then we go for bone marrow transplantation, but sometimes due to infection, they would be dead because of this kind of cancer. Thank you for your hearing. Please take the